Hello and good morning, good afternoon, and good evening, depending on where you're joining us today for our fifth session of SalivaDirect Inc.'s annual conference. We're very excited to have a number of panelists today who have some pretty strong connections and partnerships with our SalivaDirect Inc. organization. Looking forward to hearing from each of them. Before we get started, I wanted to do a couple of housekeeping items. First of all, my name is Brittany Choate. I'm Director of Programs with SalivaDirect Inc. And it's my pleasure to welcome you today to this session, which focuses on increasing diagnostic access through patient-centered programs. Very excited to introduce our first presenter, who is joining us from Malawi. Lukerensia Mlongoti is from the Malawi Liverpool Wellcome Research Program. And she's going to be sharing with us about the implementation of a saliva-based low-cost diagnostic assay, SalivaDirect, for the detection of SARS-CoV-2 and other respiratory viruses in Malawi, a low-income setting. Lukerensia, over to you.
Hi, everyone. So firstly, I would like to thank the organizers for giving me this opportunity to speak at this year's annual conference. It's a pleasure to be part of this great conference. My name is Lukerensia Mlongoti. I am an early career researcher from the Malawi Liverpool Wellcome program, and I work from the Infection and Immunity group, of which is led by Professor Kondwani Charles Jambo. I hold a BSc in Biomedical Sciences, and I'm so happy today to be sharing with you our work. My talk is on the implementation of a low-cost saliva-based diagnostic assay for the detection of SARS-CoV-2 and other respiratory viruses in Malawi, a low-income setting. So respiratory tract infections still remain a major global burden, as we see that they are the major causes of illness as well as deaths, with the highest burden being experienced in the low-middle-income countries. So in 2021, there were 344 million Eastern cases of lower respiratory tract infections and 2.18 million deaths globally, and 75% of these deaths were occurring in low-middle-income countries. The burden of respiratory tract infections is very high in children as well as the elderly. In 2021, there were 37.8 million cases of lower respiratory infections and over 501,900 deaths globally in children under the age of 5. And in 2016, there were over 1 million deaths in adults more than 65 years old, which were caused by lower respiratory tract infections, of which 13 to 31% of these were reported to be caused by respiratory viruses. So these pathogens are primarily caused by viruses, as well as these respiratory infections are mostly caused by viruses as well as bacteria. What are the key pathogens that are responsible for respiratory tract infections? For the viruses, the most common are respiratory syncytial virus, human rhinoviruses, human metapneumovirus, human parainfluenza virus, influenza A/B, and for the bacteria, we have more of Streptococcus pneumoniae, Mycobacterium tuberculosis, Haemophilus influenza, as well as Streptococcus pneumoniae. So respiratory tract infections are classified as upper as well as lower, and this is based on the location of the infection within the respiratory system. Upper respiratory tract infections include otitis media, laryngitis, sinusitis, as well as pharyngitis. And these ones are usually mild as well as self-limiting. But the lower respiratory tract infections include bronchitis, bronchiolitis, as well as pneumonia. And these ones are usually severe as well as life-threatening. So in many developing countries, especially in these low-middle-income countries, including Malawi, the diagnostic capacity for infectious diseases is mostly challenging. And this is because we have the limited capacity to detect these most causative agents that are responsible for respiratory infections. As such, because the individuals who still present with the symptoms of respiratory infections need to get treatment, most of it is based on the empirical treatment. So they are given treatment based on the symptoms that they are showing instead of the actual diagnosis, because we are limited to the diagnostics that we can do. And then this has been associated with increased use of antibiotics, as most routine antibiotics that are being given to these individuals, since the symptoms of viral as well as bacterial infections are usually overlapping. And recently, there have been increased cases of antimicrobial resistance worldwide, and this has also been experienced in Malawi. A recent study that has been conducted showed that there is increased resistance, and this is due to mostly these antibiotics that are usually administered. And these increasing challenges in diagnostics highlight the need for increased surveillance, especially in these low middle income countries. So I'll give an example of Malawi during the COVID-19 pandemic. So in 2021, Malawi had reported only 0.1 new COVID-19 cases per week per 1,000 people, as compared to the number of cases that were reported in the US, which were 121.1 per 1,000 people as well per week. So we can see that there were low reported cases in Malawi, but however, a cell prevalence study that was conducted in healthy blood donors had shown that a lot of individuals were exposed to this pathogen, but then we had low case counts. So we see that we have more cases that are undetected and they end up being unreported. And these untreated infections may have a vaccine escape variant, which is a threat for vaccine effectiveness. Having facing this challenge, which is due to diagnosis, we see that implementing affordable and sustainable diagnostics like saliva-based tests can help to enhance detection as well as support control strategies. So, but then the most current standards that are used to detect these respiratory infections depend on the use of nasopharyngeal swabs. So how do nasopharyngeal swabs compare to saliva samples? So we see that the nasopharyngeal swabs, which are currently the gold standard, are invasive. They cause discomfort and as well can be painful during collection. Also, collection of nasopharyngeal swabs required trained healthcare providers, and this increases the risk of these healthcare providers to the different infections of which the participant might be carrying. In terms of the saliva, it is non-invasive, it is cost-effective, and requires minimal preservative conditions. Saliva samples can also be self-collected by the participant, and also it is suitable for frequent repeat testing as it is non-invasive. Previous studies that have been conducted have demonstrated that saliva can be a reliable diagnostic specimen type for diagnosing respiratory pathogens. So I'll give a summary which was summarized by Laxton as well as Peno. And this one, we're summarizing the comparison of saliva to different samples, of which the other samples were used as a reference, and they were comparing the performance of saliva. So a number of studies were included, of which most of them, they were comparing saliva to nasopharyngeal swabs, nasopharyngeal aspirates, nasal swabs, sputum, as well as serum samples. So what they were finding was that the ones that I have highlighted are the respiratory pathogens. So we see that they also compared how saliva was performing when compared to the other reference samples in terms of detecting RSV, parainfluenza virus, human metapneumoviruses, influenza A/B, human rhinovirus, coronaviruses, as well as adenovirus. I'll give an example of one of the studies that was conducted, which is the number 4. So we see that they were comparing how saliva was performing in reference to the nasopharyngeal swabs. And the ones shown in green are the ones of the samples which were positive on both saliva as well as nasopharyngeal swabs. So we see that a higher percentage of the samples were positive on both saliva and nasopharyngeal swabs. A lower percentage of the samples were positive on saliva only, which is shown in blue, and another percentage of the samples, which was less, was also positive in nasopharyngeal swabs only. So overall, the studies that have been conducted in different places have shown that there is a strong concordance between saliva and the standard references in detecting the different respiratory pathogens. So one of the assays that has been used using saliva is the SalivaDirect. So that was initially used for SARS-CoV-2, but then it was later on expanded to detect other respiratory viruses. So we see that this SalivaDirect method is extraction-free protocol that was developed in 2020. It is a low-cost and non-invasive molecular test that uses saliva, and it received FDA emergency use authorization, and it has been adopted in over 8 million tests across more than 200 labs globally. It is globally useful, especially impactful for sustainable testing in low resource settings. So in countries like Malawi, where diagnosis is becoming challenging, we wanted to implement this SalivaDirect method to see how it is performing and if it can be used to detect the respiratory viruses. So in Malawi, we have an existing study that is looking at the respiratory viruses. It is looking at more than 12 respiratory viruses. And this study started in 2021 and it is still ongoing. So this is a map of Malawi. And this study is being conducted in Blantyre City, which is the second largest urban center, and it has more than 5% of the total Malawian population. So this study is being conducted in in 6 different primary healthcare facilities, and the main aim is to estimate the viral prevalence, understand symptom patterns, as well as monitor service uptake in primary healthcare facilities. So the SalivaDirect study has been embedded in this ongoing surveillance study, and the aim of the SalivaDirect is to evaluate the effectiveness of saliva as a low-cost diagnostic option for detecting 4 respiratory viruses. How we are doing it is that we are collecting paired samples, nasoophageal swab samples as well as saliva samples. So far, we have collected and processed over 2,000 samples, but for the sake of this talk, I'm going to give results for the 1,536 samples because the other ones haven't been analyzed yet. So for the nasoophageal swab samples, we are using the gold standard testing method, of which we have 50 microliters of the sample mixed with 6.5 microliters of proteinase K, and proteinase K is just an enzyme that will help break down the proteins that are in the sample. And then after mixing, we heat the mixture at 95 degrees on a thermocycler for 10 minutes, and this is to heat inactivate the proteinase K. And later on, we do DNA extraction using the column-based method, and we use the QIAGEN kit. All this is detected using a reverse transcriptase quantitative PCR. For the saliva samples, we take 50 microliters of the saliva and mix with 6.25 microliters of proteinase K. After mixing, we heat on a thermocycler for 5 minutes. So this is the extraction-free protocol, and we are comparing the results that we are getting in these methods. For our participant characteristics, the total participants are 1,536, and their ages, the minimum age is 1, and the maximum age is 88. The median age among our participants is 28, the 25th percentile 19, and the 75th percentile 35. 41.3% of our participants are males, and we have some who are suspected COVID-19 cases, and these are the ones that have one or more of the symptoms of fever, cough, runny nose, loss of taste or smell, wheezing, shortness of breath, vomiting, headache, sore throat, fatigue, or chest pains. So we also have vaccination status of our participants, which is the COVID-19 vaccination status, of which these are the ones that received the COVID-19, regardless of which vaccine they received. And 18.1% of our participants are the ones who got the COVID-19 vaccine. Looking at the performance of saliva versus nasopharyngeal swabs in detecting the respiratory viruses, so we're looking at 4 respiratory viruses: SARS-CoV-2, respiratory syncytial virus, influenza A, as well as influenza B. In terms of sensitivity as to how saliva was able to detect the true positives correctly, we saw that for SARS-CoV-2, sensitivity was 68.8%. For respiratory syncytial virus, we got the sensitivity at 88.6%. For influenza A, it was 86.8%, and for influenza B at 85.7%. In terms of specificity, we say that for SARS-CoV-2, we got 99.6%, for RSV, 99.9%, for influenza A, it was 99.1%, and for influenza B, it was 99.9%. We were also able to look at the positive predictive value, which tells us the likelihood that a positive test is truly positive, and the negative predictive value is telling us the likelihood that the negative test is actually means that there is absence of the disease. So we also looked at the kappa, the concordance, which is the agreement between the two methods that we were testing. For SARS-CoV-2, the kappa was 0.76, which shows that there was a substantial agreement. And for RSV, we got an almost perfect agreement, which was at 0.915. For flu A, we also got 0.8, as well as for influenza B. And for the magnanimous p-value, we saw that there was no statistically significant difference in the detection of the viruses for the two methods that we were testing. So saliva had shown substantial to almost perfect agreement with NPS across all our 4 viruses. We also compared the detection rates between NPS as well as saliva. So A is showing the numbers of the samples based on each of the viruses that we were looking at. So because we were using NPS as the reference and we were comparing to saliva. So we see that the first quadrant here, we have the true positives. And here, the next one, we have the false negatives. Here we have the true negatives and we have the false positives. So 75 of the samples out of the 1,536 were positive on both of the methods for SARS-CoV-2. So the ones shown in the first quadrant here were the ones that were positive in the two methods that we were testing. And the ones that are shown to the right here are the ones that were negative on saliva, but were positive on the NPS. And right here, down, they are the ones that were negative on the NPS, but then were positive on saliva. And the same as here, which were the ones that were negative on both the methods. So B is showing the actual rates that we got after comparing the methods. So we see that 64% of the samples. So this is showing the percentage of individuals against the specific virus that we were comparing. In terms of SARS-CoV-2, the ones that are shown in blue are the ones that were positive on both NPS as well as saliva. And the ones that are shown in pink are the ones that were positive on NPS only. The ones that are shown in purple are those that were positive on saliva only. So 64% of the samples that were positive were found to be positive on both NPS as well as saliva, and 29% were positive on NPS only, and 7% were positive on saliva only in terms of SARS-CoV-2. For RSV, 85% were positive on both methods, and 11% were positive on NPS only, with 4% positive on saliva only. For influenza A, 80% were positive on both methods, 12% positive on NPS only, with 8% positive on saliva only. In terms of influenza B, 80% were positive on both methods, with 13% positive on NPS only and 7% positive on saliva only. So what we show was that saliva had shown comparable performance to NPS for detecting respiratory viruses, with most cases identified by both methods, and a few were detected by only one method as either positive on NPS only or positive on saliva only. We also compared the CT values, which are the quantitative values that we were getting. And this one is showing that for all the pathogens that we were comparing, flu A, flu B, RSV, as well as SARS-CoV-2, looking at the CT value against the sample type being NPS or saliva. The blue is for NPS and the yellow is for saliva. So we're seeing that across all our four viruses, we were getting higher CT values in saliva as compared to nasopharyngeal swabs, which means that we're getting more RNA copies, we're getting more viral copies in NPS as compared to saliva samples. And this is what we observed, that lower CT values were observed when we were using NPS as compared to saliva for all our four viruses. So just to summarize whatever I have talked about here, we see that we have challenges in diagnosis of respiratory infections, and this is a huge problem as it can delay appropriate treatment, it can limit timely outbreak control, as well as it can weaken the surveillance system. As such, accessible and scalable diagnostic tools are critical, and this will help to improve surveillance, especially in resource-limited settings. Our results are showing that the SalivaDirect platform is offering a cost-effective as well as non-invasive method for detecting the key respiratory pathogens, especially in low- middle-income countries. And we see that this platform can enhance the surveillance of respiratory viruses, providing comprehensive data that can help in forming public health policies, as well as including looking at the prevention as well as vaccination strategies. And then way forward, what we aim to do next is that we want to understand the differences that we are observing between the nasopharyngeal swabs as well as saliva samples in detecting these viruses in terms of sensitivity as well as the viral load. So different studies have already looked at this as to what causes these differences, of which some of them mention in terms of duration of symptoms as based on when the symptoms had started and the time that the samples were collected as well as processed. So other studies have also mentioned of saliva having prolonged shedding of these viruses, which could also be one of the factors that are affecting our results. And lastly, I would like to acknowledge Professor Kondwani Jambo, Dr. Annie, Dr. Chikondi, Dr. Oki, Dr. Lusago, Hilbert Shalon, Chikondi Julius, our study participants, and the infection and immunity group of which I work in. And these are my links to connect. And as well, I would like to thank everyone for listening to my talk. Thank you.
Thank you so much, Lukerensia. That was a wonderful presentation and certainly great to hear how the SalivaDirect assay has been deployed out in Malawi. We're going to transition now from Malawi back over into the US side of things with Dr. Lior Rennert, who's joining us from Clemson University, specifically the Center for Public Health Modeling and Response. Lior is going to be sharing with us about disease modeling and analytics to guide allocation of mobile health clinics. Lior, over to you.
All right, thanks for having me today. We are doing a lot of great work here, and I'm just going to go ahead and get started so that I can share as much as I can in the limited time that we have. So just a very brief background, not that I have to refresh everybody's memory on the threats of pandemics, but they occur more often than folks think. We know about some of the famous ones, the Black Death, which killed up to a quarter of the world's population. The 1918 influenza pandemic, which is estimated to have killed between 3 to 6% of the population, the HIV pandemic, which killed about 1% of the world's population. But pathogens with high pandemic potential just have substantially increased over the last couple decades. That's due to globalization, really just increased urbanization, human population, which leads to deforestation, animals coming out of their natural habitat, and ultimately increased animal-human interactions. We remember that the original SARS virus had almost a 10% kill rate, but it only infected 8,000 people because you were not contagious until you had symptoms, so it was much easier to control. On the other hand, SARS-CoV-2, the virus that causes COVID-19, led to way more cases and therefore deaths. So even though the death rate was lower, it killed so many more people because you could become infectious before you had symptoms. And therefore, the more cases you have, even with a lower death rate, the more deaths you're going to have. Now, as bad as SARS-CoV-2 was, and it would be devastating if anything like that happened again, there is potential for even worse than that, right? There's nothing stopping a mutation from the original SARS virus to be able to transmit before people present symptoms, and therefore you could have a 10% kill rate with the infectivity of SARS-CoV-2, and you're just going to have much more devastation. So how do we prepare in this setting, and what could we have done better during COVID? Well, obviously, in the good times, right, you want to beef up your potential response and your infrastructure as much as possible. So that means more ventilators, better tests, quicker pathway to vaccines. But when a pandemic or an outbreak hits, you're really stuck with the resources that you have in that moment. And one thing we know is that the quick and efficient allocation of essential resources saves lives. And we remember throughout the pandemic, these were limited. First, it was ventilators, and then masks, and then testing kits, and vaccines, and then treatments. And this poses daunting challenges for decision makers. And that doesn't just include hospitals, it's health departments, it's universities, other large corporations and institutions. But if you can have efficient resource allocation, you can improve health outcomes. The example I'd like to give is at Clemson University. At the start of the fall 2020 semester, we had very limited testing. And we have a student population of about 20,000. We had about a few hundred tests a day that we could have. So rather than just doing symptomatic testing or random surveillance testing, we did some random surveillance, but if that detected a potential outbreak in a residence hall or a floor of a residence hall, we just used whatever available test we had that day to test the entire floor of that residence hall. And what we found was that was twice as likely to detect positive cases and limit disease transmission. So by just the simple data-driven approach, we were able to double the effectiveness of our testing resources, which is huge. When we think about treatments and getting FDA approval, even a 10% improvement in your typical pharmaceutical intervention will lead to a new potential product. Here, we're talking about 100% improvement without having to do too much at all. So that's really the basis for what we're going to talk about today. So we are part of InsightNet. It's a national outbreak analytics and disease modeling network funded by the CDC Center for Forecasting and Outbreak Analytics. SalivaDirect is a part of this as well. Our specific proposal is called DMA Prime, Disease Modeling and Analytics to Inform Outbreak Preparedness, Response, Intervention, Mitigation, and Elimination in South Carolina. Our mission is to develop a statewide network for outbreak detection, forecasting, and coordinating emergency response. And that last part you're going to see is where the mobile health clinics and where saliva testing comes in. So just very briefly about how our center works, we integrate many data sources, EHR, digital trace data, that's Twitter, Google Trends, X, wastewater sampling, and community characteristics as well. We process the data, analyze it, use it to detect outbreaks, develop forecasting models, put that all into software for decision support, and ultimately inform emergency response and other public health interventions. So why are we as a analytics center and for outbreaks in the business of coordinating emergency response? Well, we know that healthcare in the U.S. is extremely fragmented, and this hinders emergency response coordination. So if we're developing software for multiple health institutions and stakeholders, we have improved information on who is doing what, and that can increase coordination during health emergencies. So right now we're working with the Medical University of South Carolina, Prisma Health, Clemson Rural Health, South Carolina Center for Rural and Primary Healthcare, and the South Carolina Department of Public Health. And just to give an example, during the COVID-19 pandemic, the mobile health clinics were used by multiple institutions, but it would happen, for example, that our health system would send a mobile vaccine clinic to the same location at the same time as the health department, because it was tough to coordinate, during the emergency. There's so much going on and there was no infrastructure to do that ahead of time. Now, at that time, we were getting hundreds of people coming out to the mobile vaccine units to use them. And what that means is that that's hundreds of people we could have vaccinated elsewhere if we would have just coordinated. So this really goes beyond just the individual institutions. It's really the sum. The sum is greater than the individual parts. So just currently, COVID-19 and mobile testing vaccine units, Prisma Health served about 12,000 vaccine doses to 150 medically underserved South Carolina communities in 2021. Most of these individuals did not have insurance or were on Medicare or Medicaid. Clemson Rural Health provided testing to 11,000 individuals from underserved communities. So what we are doing is delivering saliva-based testing to strategic hotspots for outbreak detection and containment in underserved communities, and that's via partnership with the Clemson University Ready Lab, Prisma Health, and Remedy, with consulting from SalivaDirect. So I am going to try to share a video. Brittany, I'm just going to ask, sorry, if this doesn't work, please just let me know and we'll just skip it. But I think the video does a much better job than I do at describing our work. So let's see if we can do this here. Everyone hear the video okay?
Yeah.
Thanks.
Healthcare access is a big problem for a lot of Americans, and mobile health clinics are vehicles that deliver healthcare to underserved populations. So it's not surprising that during the COVID-19 pandemic, they were used primarily for infectious disease screening and vaccine delivery.
So during the pandemic, those who were experiencing vulnerabilities were the most likely to die or be hospitalized from the virus. And so certainly South Carolina is a very rural state. We're a relatively poor state, and so we see more of those disparities here.
Our goal is to develop a statewide network for outbreak detection, forecasting, and coordinating emergency response. We are doing this through strategic data collection and integration, model development, collaboration with health partners, and software development. This will allow us to track outbreaks, identify high-risk communities, and coordinate emergency response so it ultimately saves lives.
Health equity is an essential building block to creating prosperous, resilient, and healthy communities. And we can't ever reach health equity if we can't provide, high quality healthcare to our rural populations. So really, this modeling toolkit is giving us an opportunity to really identify those high-risk populations and truly meet the need of our South Carolinians.
So our toolkit can identify outbreaks in each community for a variety of infectious diseases and forecast where those outbreaks are going. Additionally, it maps what resources are available so that we can better allocate health interventions, including mobile health clinics, to high-risk areas of greatest need.
I think the big difference between what we're seeing now with this predictive modeling is we have such better coordinated data. And that's a game changer for you to be able to make a decision. And I think the transparency back to community as well about how we're making decisions. And that's really important because that transparency that we can have back to our community about how we're making decisions is going to build trust.
So we're in the early implementation phase of actually using Lior's modeling toolkit. But what we're doing is identifying high-risk areas based on the map that shows us all the data that he's incorporating, and then going out to these sites to provide free screening for COVID, flu, and RSV in order to identify infections early, prevent hospitalizations, and prevent preventable deaths from these diseases.
But I think also just to treat other epidemics that we're seeing. I mean, we have an opioid epidemic in this country, and sadly in South Carolina, there are other infectious diseases that will be there. Being ready for the next natural disaster. I mean, our part of the country was hit hard by Hurricane Helene. Mobile health centers and mobile health clinics can help really be an answer to that. And so to have a coordinated way that we're taking care out into the community, regardless of what our public health emergency is going to be helpful.
And thanks to the work we have been doing here, we can now send mobile health clinics out to high-risk communities in a more effective way and ultimately save more lives.
Okay, so let me just quickly get back to my presentation. Brittany, I saw your message about the time. Swap view here. Okay, hopefully my screen is sharing again. So briefly, we talked about expansion. So it's not just infectious diseases. Obviously, saliva-based testing, mobile health clinics can work for a lot or be adapted to a lot of conditions. We currently have an NIH grant to deliver opioid use disorder treatment in rural communities. So that's sending out a mobile health clinic with a peer support specialist and using our data analytic approach to identify the highest risk communities. And we did find that our intervention did substantially increase initiation and retention rates. We obviously are centered to identify where the hotspots are. We can adapt our modeling frameworks, look at opioid and HCV and related conditions, look at where the actual high-risk communities are, both for risk of overdose or HCV hospitalization, but also where the resources are. The models are fairly accurate here. I think in the slide I included the link to the publication if anyone is interested in looking further. We also looked at where the HCV screenings are and factors associated with MHC utilization, positivity rates, and initiation rates for HCV. Not surprisingly, impoverished communities, those with high uninsured rates, and those with greater distance to medical facilities. So that's why the mobile health clinics are so important and why we have to increase utilization. So utilization really varies for our HCV screening. We get a median of 4 people per visit, a range of about 1 to 36. Now, 4 is actually pretty good for HCV, but if we could park these clinics in more effective and strategic places, we can get a lot more people to come out. And we used a GIS-based approach to minimize driving distance for uninsured individuals aged 35 to 64. That's primarily who is in need of HCV treatment from these mobile health clinics, and it can increase the population served by over 90%. This can, of course, be expanded to HPV vaccination via mobile health clinics. And so very briefly, I want to talk about just the software at the end. We've seen how it can, prevent pandemic prevention and response, resource allocation and mobile health strategies, and broader efforts to reach underserved populations. And the same thing that we do for DMA prime here for infectious diseases can be extended to other conditions. Everything we do here is scalable. We talked about a conceptual framework. We identify effective interventions, where the demand and need is, where the high-risk regions are, and putting it all together to increase response. Very briefly, want to share the software, and I think it'll actually just be easier. Can everyone see my web browser okay?
Yes, it's showing just fine.
Yeah.
Okay, great. I think this will be a good use of our last couple minutes. I just have to, for HIPAA, do the two-factor thing here. All right, so we have a bunch of dashboards: respiratory, virus, wastewater, outbreak detection. So quickly, how it works. So this is looking at, COVID-19. So we can click on a given region or a zip code here, and we can see, okay, we're projecting in the next. We're still working on automating this weekly, but the last time we ran this was on May 18th. So we projected there 34 hospitalizations in this particular zip code in Georgetown County with a slight decrease. It's been a weird COVID season where it's been just pretty stable at a, moderate to low case count. But if we want to know where the highest risk regions are, it's color coded here. We can map out where the historical mobile health clinic locations are, where the hospitals are, so that we're not, overlapping. And I'll talk about that in a little bit. We could also search for the highest risk communities. So this is alphabetical, but I could search it, high versus low to really see where the areas are. Sometimes we might be operating within a county, so we can restrict it to say just Charleston County over here. And we're going to incorporate, wastewater as well. So influenza A, SARS-CoV-2, whatever data we have showing trends. And I think that for the rest of it, I'm just going to come back to our software just so I don't show anything HIPAA related. But we could also use from our health system outbreak detection. So where are the cases that we're actually seeing for each disease as the data comes in? We talked about opioid overdose, HCV. And then this is something that we're building as well. We could also track where the mobile health clinics have been, as long as that institution is willing to participate with us. So now we work with Clemson Rural Health. They send us, essentially, we automate a Google sheet that just puts in the locations of where they went. So here at this event, we screened 5 people for HCV at this location, at this date. And what we're going to work into here is the ability to add where you are going in the future so that we can better coordinate response and other institutions can see where you plan to go so that there is no overlap. Very briefly, our next steps is incorporating the wastewater into our forecasting framework. I didn't talk about that a lot, but it's a little bit tricky when you're integrating across multiple data sources because they're collected at different times. There's a lot of missing data, and anyone who's ever fit a statistical model knows that if you have a little bit of missing data in a given observation, whether it's for an individual or a community, the model throws away everything. So we're trying to work on incorporating that, tracking the proposed locations for future healthcare delivery, including mobile health clinics, and providing real-time summary statistics, incorporating our GIS-based approaches in the software. So when you identify a region, the software will tell you where's the best place that you can park the unit, and working with your community partners in order to do that. And then, of course, we want to pilot test this in real-world settings. Of course, we talked about extensions. We know in non-pandemic settings, it is heart disease, diabetes, cancers, drug overdoses that are the leading causes of death and medical expenditures. And these individuals are also at greater risks of during infectious disease outbreaks. So we're simultaneously, working to reduce the size of this. We're working to treat people today, but reduce the size of the susceptible population tomorrow, during a future infectious disease outbreaks. And it allows us to pilot test this framework. So this is really a scalable approach, and anyone who's interested in a collaboration or interested in expanding this approach to their own public health needs or healthcare delivery needs, please don't hesitate to reach out. Thank you.
Thank you, Dr. Rennert. Appreciate you getting to share about the software and the modeling and all the work you guys are doing out in Clemson. Beautiful. Finally, our last presenter is going to be sharing with us information from his work at Brown University. Dr. Yasin Abul is going to be showing about respiratory outbreaks in nursing homes, identifying and managing unconventional presentations.
Great. Hello, everyone. So I am very impressed about this work, and previous presenter did a great job. Actually, I am more excited right now. So I am a geriatrician and a pulmonologist and infectious disease specialist. I will be presenting today the respiratory outbreaks in nursing homes and identifying and managing unconventional presentations. And I will be concentrating on some of the testing strategies as well. So these are my conflict of interests. I received and receiving some grants from CDC and the pharmaceutical companies, and I'm the education member, some global clinical trials as an ID physician and a pulmonologist. So those are my learning objectives today. So understand most of the actually respiratory pathogens, and in older adults particularly, and particularly in nursing homes. And I will try to define respiratory outbreaks in nursing homes based on our data from VA nursing homes, and I will also try to concentrate on transmission dynamics and the typical presentation, atypical presentation, and the importance of actually the testing and other things actually. So this is the study from Wisconsin, from 20 nursing homes, and it's before the COVID-19 pandemic, just before actually, between 2016 to 2019, and it was published in 2020. So you can see these viruses here. So we are all familiar with these viruses. It's good to see them in nursing. It's good to see we detected them in nursing home environment actually, which is not easy. So, and you can see the numbers very evenly distributed here. So that means they are there, and most likely we are not aware of them because of underutilization of the testing. So this is the reporting from CDC and CDC website and nursing home data set from older adults living in nursing home, and we only see, look at here. So we only see the COVID-19 reports till the January 5th, 2025. So we are, as a nation, we are aware of the COVID-19 at that time. And then CDC started to implement, to report RSV and influenza cases starting from January 5th. So, but that doesn't mean that we don't have other viruses in nursing homes. So this is our CDC and the ABT study. So we are doing these ones since 2024. And this is not an on-site protocol, but we are swapping symptomatic cases, only symptomatic cases, and sending to the central lab. And we are trying to make a surveillance for nursing homes over 7 states actually, and over 50 nursing homes are participating in this study, and we are trying to find these viruses which are there for causing some problems, including frequent hospitalizations and exacerbations of underlying diseases for our lovely older adults. So you can see the human rhinovirus and enterovirus here, influenza A, SARS-CoV-2, parainfluenza, and the respiratory syncytial virus. But even here, you can see in the February-March period, and February is the peak month. January and February is peak months for the respiratory syncytial virus. We don't see it. So why is the big question actually? So, and I will show some slides about it. So what are the challenges in respiratory infections in older adults? So they are not presenting typically, first of all. So they are not like younger adults, like a 20, 30, 40 years old, and 50 years old younger adults. So after age over 65 particularly, they have different signs and symptoms. And we will come to these ones actually. And this causes delayed detection. I think this is the most important part, and also delayed care. So, and they have complex comorbidities, and they have congestive heart failure, COPD, and these underlying diseases can be also exacerbated, and most of the time we can say this exacerbation is idiopathic, but most of the time it is because of the viruses, and they have degrees physiological reserve, and that means they cannot actually respond very well to compensate respiratory virus infection, and their immune system is also not as good as the younger adults, which is called immunosenescence. And so this is called the aging of immune system. So basically impaired immune system from the point of T cell functions, neutrophil functions, immunoglobulins, and even for the first barrier systems in the upper respiratory tract from the point of immune system problem. So that's another problem, and it affects also the vaccine response as well. So another one is underutilization of the vaccinations in older adults living in nursing homes, and also underutilizations of antivirals. If we don't know the viruses, which viruses are causing all these hospitalizations and underlying mortality, with the testing, I think that's the most important cause of the underutilization from the point of awareness, actually, and under recognition. So, and we don't have timely applied multiplex point of care diagnostics. So it is not easy to perform nasopharyngeal swab for a frail older adult. So imagine, so it is not easy, and it can cause some complications as well. So those are the challenges in respiratory tract infections detection and the treatment in older adults. So look at these ones. So we all familiar with the nasopharyngeal swab. I'm not sure whether you had in the past or not, but I had, and it is not fun to have it. So what we should we consider it is safe or comfortable. So look at here. So this is the septal line here. So this is the perfect spot to reach out this spot, the ideal area for the swab. But if you lose this angle, actually, so, and it's a 30-degree angle from nasal floor, which is here. So you may enter the danger zone, and you can cause some epistaxis and some you can go into the brain and cause some cerebrospinal fluid leakage. So it is not a perfect actually test from the point of frail and the vulnerable older adults. It's a great test from the point of yield and reaching that spot to get to some viruses and have the positive test, but it might not be a good choice for the older adults actually. So key issues, I just try to put this one here as a table from the point of nasopharyngeal swabs in older adults and the nursing home residents. So those older adults have some upper respiratory tract changes during the aging. So they have less mucus secretion, and their noses are dry, and they are on some positive pressure ventilation if they have sleep apnea and the morbid obesity, so on and so forth. Those are causing lots of upper respiratory tract changes, and they are at risk of epistaxis. So it's very, very common and very commonly seen whenever we do this kind of nasopharyngeal swab there. Even with the nasal swab, we can easily see the epistaxis, and especially they are most of the time on antiaggregant, which means aspirin, and the anticoagulant, which means blood thinner. So those are contributory factors to epistaxis. And retained broken swab, yes, that's reported, and it's not rare. And they have also some mild to moderate or severe cognitive issues. So this will cause some communication problems also, to make sure we are doing that nasopharyngeal swab actually is correct or not. So this make the procedure more distressing for sure, and from the point of patient for sure, and from the point of provider as well. So because there is no communication if the patient has moderate dementia or severe dementia, right? So sometimes require sedation. I don't think it's a good idea to give somebody a sedation for nasopharyngeal swab. And technical errors, increased risk of false negativity because of this improper technique, particularly in the older adults. And the recurrent testing burden is the main problem in nursing homes to catch the respiratory outbreaks. So we have to repeat testing. Imagine if you want to do nasopharyngeal swabs, even the nasal swabs during the outbreak in the nursing home, it's going to be a huge burden for residents and the providers and the CNAs and the nurses. So that's why we need less invasive, less distressing tests for those older adults. And the acceptability, so is self-collected nasal swabs and the saliva-based testings are more acceptable. So saliva-based at the nursing swabs in older adults also from the point of patient comfort is very, very different. And it's, first of all, saliva-based assays are non-invasive, painless. Self-collection is possible, right? And the collection method is also easy compared with the other one from the point of training the staff and performing it, and from the point of also some side effects and the complications. And it is easier for frail and cognitively impaired patients, and the detection rates are very comparable, and the cost is lower, and the time efficiently in setting of outbreak is outbreak management in the active and the hectic nursing home environment. So I think from the point of diagnostic value, you guys already shared the numbers. I am not going to go over that ones, not to overlap, but it is very comparable, and it is there. And the more we use and the more we have more data, we will see the long-term effects of this detection. And the mass screening utility, it is very important in the middle of pandemic, but not just in the middle of pandemic, in the middle of a huge outbreak settings in the nursing home environment, which is causing more hospitalizations and the mortality for these vulnerable and the frail population. And the limitations, saliva-based studies may miss some viruses by MP, but if you check, see the overall picture from the point of application and the mass screening and the other stuff, there is no study about this one to say that yield is low. So why older adults are presenting differently from the point of clinical presentation? So because they can't spike fever as high as with the younger adults because of the interleukin-6. I'm just going to bring some your attention to this right side, and their cough reflex is reduced. They can aspirate, and they have a less efficient viral and the mucosal clearance compared with the younger adults, and because they have impaired respiratory tract mucociliary function. And delayed cytokine increase is the main problem for the symptoms as well. So they may not have any kind of fever, they may not have any kind of other symptoms like shortness of breath or any kind of other upper respiratory tract symptoms, and they can present just with the confusion and the frequent falls and the behavioral changes, so which is very, very common in older adults living in nursing home, even in the community dwelling centers. So, and their response is also very, very updated and reduced response to infections, and the vaccination is also is a challenge because of the reduced T cell response, and vaccination. After the vaccination, their antibodies are also dropping. For example, for the COVID-19, and their antibodies are dropping within actually 3 months actually, and after the 6 months, they are technically not vaccinated based on our CDC study. So these are the atypical presentations for respiratory infections in older adults. And look at here. So 50% may not have cough, and almost in some of the cases, 50% may not have the fever actually, and they can present atypically with the geriatric syndromes, anorexia, which means they can't eat. Their appetite is not good actually. So and weakness, very non-specific, right? So somebody is delirious, which means they are confused, their attention is not there, and inattentive. So those kind of things are very atypical but very common in older adults to catch up respiratory tract infections, and the falls are also there, at least 14%, and the functional decline is also there to catch up these infections. So the decline in functional status here and defined as a new or increasing confusion, and the falling and the deteriorating mobility. So those are important signs and symptoms for the detection of and swapping those guys actually. So swapping those older adults, and the reduced food intake and failure to cooperate with the staff. So of course, we are not swapping, and we are not doing some tests for those patients if we don't know this actually. So that's very important from the point of geriatric perspective. So fever is so there's a definition for the fever in neutropenic fever guidelines, as we may know. So 100.4 is the magical number, but that's not the case for the older adults. So they can increase their temperature because their thermostatic features are different. So they can increase their baseline temperature, and we can define the fever from, and we can go from there. So repeated oral temperature 99 Fahrenheit or rectal temperature 99.5 Fahrenheit is deep fever actually for them, and increasing baseline temperature from the point of baseline temperature 2 Fahrenheit or 1.1 Celsius over the baseline temperature is fever as well. So, and this is a slide which is showing the simple act of breathing is the problem here, because it is not easy to contain, right? So they are coughing, they are sneezing, they are speaking. So the respiratory route, that's why, is the most likely mode to lead outbreaks in nursing homes and the pandemic spread, and interventions to interrupt respiratory transmission are more challenging. And so why those nursing home residents at high risk for respiratory viral infections is the great question, which I tried to explain. And I will look at the next slide for the other viral outbreak interactions from the point of virus, environmental factors, and the host factors. And so I think viral factors is number 1, and the environmental factors number 2, and the host factors number 3. But this is not in rank order; they are interconnected. And when we look at the viral determinants, so each virus has unique ability, whether they have envelope or whether they have capsid structure, RNA or DNA viruses or not. So those are all important from the point of viral determinants, because capsid structure also can cause variability. And RNA viruses are more important to spread because of their high transmission potential because of the mutations. And those are the environmental drivers for viral spread, which are very important and which is well known in nursing home environment. And nursing homes are closed living quarters and shared facilities, and the healthcare workers there moves from room to room, and visitors are there from outside to the inside, and the ventilation is the main problem as well. And the short range and long range transmissions in long-term care facilities are the main culprit for the respiratory tract infections, and also transmission modes and the rates and the high mutation rates are very important, and those are also causing some challenges in control from the point of diversity, rapid adaptability of the RNA viruses. It is difficult to control. So this slide is summarizing all I actually went over. So it's a great slide to check and these interconnected factors with the nursing homes and the malnutrition, frailty, decreased physiological reserve, and the polypharmacy. And those are the risk factors which I already mentioned about for atypical presentations, age, multiple chronic medical conditions, and cognitive impairment, so on and so forth. So, and those are the other factors which I already mentioned about the atypical and unconventional presentation. And the 35% of older adults with acute infection may just present with atypical symptoms and absence of fever. And this is the number for the vaccination. Since they are presenting atypically, since we are not catching up them and with the swapping and with the efficient and the rapid testing, so those are also affecting the vaccine uptake and the antiviral uptake. And we have very different range of the incidences, for example, for the viruses there, for the respiratory infections. That's the reason which we had this kind of 1.51 to 85.2 actually presentations, and these are very actually different. So that's why we need more and more swapping and more efficient testing. So this is my last slide, and I would be more than happy to answer your questions, and hopefully it's helpful from geriatric perspective.
Thank you, Dr. Abul. Very much appreciate you getting to share your perspective and the research that your team has done specifically on older adult populations. At this time, I'd like to invite all of our panelists to join us for the live Q&A portion of this session. For those of you who haven't had the opportunity, please use the Q&A function at the bottom portion of your screen to enter a question in the chat, and then those will be read out loud and asked of our panelists. The first question that came through is actually for Lukerensia, and that is, would you mind sharing some more about your collection process, the dispersed way that you've been able to collect samples, and perhaps some information about how community healthcare workers or those in the local community have been involved in that collection process?
Okay, not sure if I'm getting it right, but then the correction process is that, so we are collecting the nasopharyngeal swab as well as the saliva samples at the same time. So it depends on the age group. When they are children, they just use a pipette and then they just get from the mouth. And when they are adults, they drew on their own. So that's how we collect the samples. But the last part,
the question was asking if community health workers have been involved in the collection process.
like if the health care workers are getting involved?
Yeah.
Yes, they're getting involved. They are collected from the clinic. Yeah. So
Wonderful.
yeah.
That's fantastic to be able to utilize those local resources to be able to test in a bunch of different settings. Thank you for confirming that.
Thank you.
Absolutely. The next question that came through is for Dr. Rennert, and the note was, first, what an amazing program you're running. Do your mobile opioid clinics include MAT, routine therapy, crisis services, or is it more about connecting people to service and education? Do you include coordination of care for patients?
Yeah, that's a good question, and just so I accurately state my role here, while I am PI I'm a multi-PI on this project, but even though I led the proposal, the team running this is actually the Prisma Health team. So I can speak specifically to what we provide in this current grant, and that is medication against opioid use disorder, which is medication-assisted therapy or MAT, as part of the grant. And Prisma does this outside of this specific grant as well. They have other funding for that work. So yes, we do include MAT. As part of the crisis service and connecting people to service, one of the unique things we included in this particular trial is connection to a peer support specialist, sometimes referred to as a peer recovery coach. And what we found so far in our pilot study is that it does increase initiation into MAT and retention, which is a big problem with this population. It's hard to get people initiated, and it's even harder to keep them on medication because of all of the challenges and barriers they face. My understanding is, yes, they will coordinate between other services as well. I'm not exactly sure what the cascade of care is once they leave our mobile health clinic, but because they're part of the Prisma Health network and Prisma Health covers about a quarter of South Carolina, there's a lot of options for these patients besides just the mobile health clinics.
Thank you, Laura. Appreciate that. The next question is for Yasin, and that's with all the benefits that were listed for the value of saliva-based diagnostics. What do you think is the biggest limiting step to for being more widely used, particularly with older adult populations?
Yeah, I think okay, not muted. Yeah, so I think definitely there are some advantages, lots of advantages for the saliva-based studies and the swabs for the nursing home population, which I already mentioned. So some of the let's say constraints and the barriers are, so we need more data for the nursing home population, so which we are trying to get right now. So we applied, I think, right now 2 grants, and we are waiting for their response. And if we have more data, particularly in the nursing home population, I think that will be easily used in this particular setting because it's a great fit actually. So they are very frail, as you can see. They can have all the complications with the other swabbing methods. Not even the complications, and the yield is at the end of the day might not be the best actually with the other swabbing methods because the acceptability of the swabbing and the sampling and other things. And there is no data about this one in nursing home population, so I don't see it actually. So I think that's the most important part we should concentrate on.
Absolutely, absolutely. Establishing that foundation and being able to demonstrate its effectiveness. It's reminding me of all the patients that are on the other end of their perhaps like age cycle, shall we say, with the infants population that we heard about during one of our presentations yesterday, where you have those bookend populations that really could benefit from having this less invasive technique. But of course, we need more data. Thank you. Speaking of data, there was a question that goes over to Lior, specifically with the modeling and the software and everything that your team has built out. Not to put you on the spot, but what is the timeline for this kind of software and platform being able to be incorporated into other communities?
Yeah, it's a good question. So our target is in the next month to tops, to implement the software into the Department of Public Health's workflow. That will primarily be first for outbreak detection and forecasting, but then also to work that into their mobile health clinic distribution. That will likely come at some point later this year or early next year. In terms of working it into another health system or another health department or even any healthcare delivery model, it really just depends on if they are ready for it. Now, it takes some, if we're talking about outbreak detection and forecasting, the most important thing is having those data sources. So we have a lot of those data sources for local data sources for South Carolina. And that's one thing I didn't really discuss in the meeting, in the presentation today, is that in order to really inform where the mobile health clinic should go, you do need local data. While we could do forecasting for other states, it wouldn't be as easy necessarily to figure out exactly where those outbreaks are occurring without connections to the health department or health systems in that area. But if folks already have those connections and think they can get that data, then we can, of course, partner with them and very quickly adapt this software to those settings. And that's kind of the key to all this, right? When we say that this is scalable, what that means is that we don't have to start it from scratch, but we still have to do some work. Fortunately, probably 80 to 90% of the work is already done, so we can scale it up at a much smaller cost to each new system.
Fantastic information and really great to know. I'm excited to see where this continues to evolve, not only in your state, but in elsewhere and some of the other communities that we get to work with and beyond, of course. Recognizing we're at time, I want to be respectful of everyone's schedules and again say thank you to our speakers, Lukerensia Mlongoti, as well as Dr. Lior Rennert and Dr. Yasin Abul. Really appreciate you all sharing your perspectives and giving us so much to think about when it comes to how diagnostics can be incorporated in more patient-centered ways and thinking about how these tests that so many of us are involved in either developing or deploying get actually used in community and how we can continue to move and advance in that direction. Again, for those of you looking to get PACE continuing education credits for today's presentation, make sure you follow along to the VFAIR's website to look for the opportunity for you to download your certificate. There'll be a survey link that Victoria is going to post in the chat, so that way you all can click on it and give us some feedback on how you felt today's session went, as well as having an opportunity at the end of that survey to submit questions that you'd like us to bring up at the annual meeting that will take place later today. Finally, I wanted to make sure that you all remember to visit the posters that are over in the virtual exhibit hall, as well as the sponsors. They're going to be back on location and available to answer questions in the expo hall later today. And then I hope to see you all again very shortly for the next webinar that we have coming up at 12 p.m. Eastern Time, which is going to be focusing on patient-centered innovation in women's health. And then a little later on today, we have a panel on zoonotic diseases, identification and detection. So hopefully for one or both of those, and perhaps even the third with our annual meeting, we'll get to see you all again. Thank you so much again to our speakers and for all of you joining us today.
Thanks for having us.
Bye-bye. Thank you for having us.
Thank you.